Healthcare and senior care is fraught with problems and challenges, but we're also seeing some amazing new clinical treatments and resources. This show will help illuminate and uncover the good, bad, the ugly in order to equip patients, families, and other healthcare providers. Welcome to Senior Care Confidential.
Good afternoon, Brian. It's great to see you.
You as well, Joe.
Happy 2026.
Yeah.
I can't believe we're already in February.
Yep. We've already had our first ice storm.
I know. We've all gotten through it and coming out ahead. And
that's right.
Just moving
Get our
forward.
emergency preparedness stuff documented for the state for the year. So we're good. Yeah.
It's great. I know worked hard on that. We are talking today. I heard a story on the news and it just got me to do some research about some fraud that happened in LA County, that 260 hospices were shut down. And these people, these individuals opened hospices. They go in, apply for a license, but instead of applying for one, they applied for 15 or 20. And if the state saw something was funny going on, what they would do is maybe get their hand slapped, and then those people would move those hospice clients to another hospice. A lot of those patients were not even real patients, or some had already passed away, or some had no idea they were on hospice, and they go to the hospital and find out they're hospice patients, which they're not hospice patients. Goodness. And they lose those benefits. So it's very scary what's going on. I want to talk about fraud today, just stuff that's going on.
Yeah.
And how do we protect seniors? How do we get the word out on what do they do if they feel something fishy is going on?
We know with the hospice and the home health side, and even with the private duty side, there's, less of the private duty because it's not paid for by federal funds. But, on the hospice and home health side, there's two kind of conjoining entities that are supposed to be looking out for these things. One on the state side, right? Because that's who actually licensed them. We get a provider number through Medicare, but the licensing actually comes from the state. So at the California side, that's where Gavin Newsom has been cracking down on some of these. Like, what'd you say? It's 260 that they've shut down the last couple of years, whatever. But there also was a story a week or two ago where Dr. Oz, the new Health and Human Services Secretary, was out in LA because from the federal side, now, so the payment side of it, on the home health and hospice side, they were looking at fraudulent claims. And so some interesting stats. And I've been aware of these for a while because, we have a national lobbying, that's our association, but really it's a lobbying effort because we get reimbursement cuts, it seems like every year for like the last 10 years.
So what association do you belong to with home health?
There's a couple of them, but it's called NAC. I think it's National Association of Home Health and Hospice or something like that. But they are essentially, it is your membership fees pay for lobbying efforts in DC, right? Just to make sure that somebody's looking out for you, because hospitals have lobbyists, pharmaceutical companies have lobbyists. So we kind of have to make sure we get a seat at the table too. And so that's what these people do. And so there's been a lot of studies coming out in the last several years about, hey, the calculations that Medicare is using to determine the next year's reimbursement rates, there's a lot of funny business with how these numbers are jiving.
How are they? Absolutely.
Yeah. And so one of the things that they pointed out was LA County has there's roughly called 11 to 12,000 home health licenses around the country. LA County has 2% of them, but it accounts for 10% of overall home health expenditures. And so there's fraud happening there, which is why Dr. Oz went there. And so I'm glad that they're looking at it. So from a governmental agency perspective, you've got the state looking at it from the licensure perspective. We just went through state survey, 2 weeks ago. And so they're looking to make sure, hey, are you guys checking all the boxes? Are we keeping patients safe? Are we making sure, the joke about the emergency preparedness thing, right? Do you have a plan in place should ice storms happen or whatever? And so that's what the state's job is. Like, are you at least doing standards of practice that would keep our senior population safe, right? That's what their job is. And then the federal side of it is, okay, now are you actually billing for appropriate services? Are they skilled and necessary? Are you discharging them timely, and all those kind of things? And so you have two of those things. But even with that, like in the case of California or in Houston, because I know you got some stories on the Houston one too, there are companies that do kind of fall through the cracks. They're savvy owners. You don't want to call them savvy, but they've figured out how to navigate the between the state and the federal to kind of create these shell of companies where they're billing for things. There was a lot of doctors that I read about in the LA side of things where there were doctors signing orders for patients who were never even on services. And so there's that whole kind of thing there too.
That's scary. Well, I'm working with a client, as a care manager, I'm a concierge care manager. And so I get calls all the time. Joe, my dad's on hospice, but nobody's come out in 2 weeks, So one of the things that this family's complained about is they have not gotten equipment or supplies. And so they were buying everything they needed on Amazon. And the hospice blamed it on the ice storm. But the patient's been on service for 3 or 4 weeks. So, they wound up paying out of pocket. So that's not right. And they should be reimbursed for those things.
They should. Yeah.
Because hospices are making, they get a daily rate where home health is a little different. And so they need to be doing what they're supposed to do with that money they're given by
hopefully
Medicare.
They reimburse them for those because they are Medicare through the hospice they cover a lot more medical supplies than they even do for home health. So, hospital beds and those kind of things. Yeah.
But what's sad is, people that don't know, most people that go on hospice, they don't know what to expect. It's kind of like a woman going into labor. I had no idea the first time what to expect. I knew I'd have contractions and, I had no idea. So they're blind out there and they need our guidance and direction. And,
that's right.
And so I just want to say, if you do feel something's not right, you're probably right. You've got a little hunch that something just doesn't seem right. But I know there's been things going on in Houston as well. Lots of Medicaid fraud. And, what is the customer supposed to do about that? How do they know? I know most hospitals now, they have a discharge planner. And let's say they're going home on home health. They're not supposed to recommend. So what they do is they give 3 names. That's normal
or they
at
give
hospitals.
A list.
They'll give a list on a sheet of paper, just a copy of a list. And then how is the family to know, is that a good home health?
Yeah, I think it depends on the discharge plan or the social worker of the hospital. If you've got a good relationship with them, because you do want, and Medicare is really clear, like they don't have to be unbiased. If they have a good relationship or good experience with XYZ provider, home health, private duty, private nursing, whatever, or hospice, then it is incumbent upon them to share, hey, these are really good agencies that I recommend, right?
Okay, so let me ask you this. I've heard so many times from families, they gave me this list, they said they can't recommend. So is that really true? So they can make, you're saying they can.
They can advise and educate family members on their personal experience with regard to that. Now, what ends up happening though, is depending on who your compliance officer is at hospitals and how they interpret those rules. And so some places, because they want to be really careful on the compliance part of it because they read them very strictly, or they want to limit the number of home health, hospice reps, private duty reps coming in and up and on the floors. They're like, we're just going to give out a list and they can pick from there. So, we're on several of those lists and we get calls and so that's part of it. But I think every hospital is different. Every discharge planner, even discharge planners that work within hospitals, like you are just going to give them a list. Some of them don't give a list. They actually give their personal recommendation. And so I think those things are appropriate.
So I want to talk about that too. So what about that discharge planner says, this is the only hospice or this is the only home health that we use. I know there's a building that will only allow one home health.
Yeah.
They probably have 1,400 residents.
You know, like a senior living community?
A senior living community.
That's one where I do think it's appropriate. So if you think about it, this is their home, right? So you have 1,400 seniors that live in one particular location. And the resident care directors, there's usually a few nurses. That's something that big. There's probably a handful of nurses there. There's an activities coordinator. There's an executive director. And so they do want to be careful on who's coming in and out of the building, in terms of therapists and nurses and doctors. And so I do appreciate them having a narrower network at that site because that's their home. So I kind of get that piece of it. So, but it's a protection thing, right? We have good collaborative relationships with this particular home health or this particular hospice. And so we want to recommend them. I'm the beneficiary of several of those. And it is different. Like we get texts when people go to the hospitals or when they have falls, whatever. And so you want that open line of communication. If they've got 7 different agencies that they work with, all that stuff kind of goes away. So they're really trying to just make sure there's close collaboration and communication between those.
I know. And I get it for companies like yours, Brian. That's fantastic. It's a friend of the social worker at the building that they're not good.
Yeah.
And that's the only company she'll recommend. And so that's the hard thing is because we want to advocate. We want our patients to get the very best care.
Well, you remember, it's always patient choice. So even if your doctor recommends one, your social worker, your discharge planner recommends one, if you have a strong inclination of, hey, I've worked with this company before, or, you have a neighbor or a friend who's used a particular ABC home health company or hospice company before, and you want to use that one, you are well within your rights to ask and say, hey, I know you're recommending this one, but this is the one I want to utilize.
Yeah, got it.
Yep. So, websites are good. Star ratings are a little bit, those are kind of manipulated. So I wouldn't pay as much attention to those kind of things, but, reviews, certainly friends and family recommendations, look at their website and see what kind of information you can glean from there. That usually will give you like a scope of services, what their perspective is or their point of view is, how they approach home health or hospice or private duty, like what's their kind of core principles around how they do things. Those are usually good places to start.
So just a backstory, my dad, it was 2018, was in a residential care home. Just being real transparent, he never saved a dime. And so it was us children that all pitched in to help with the residential care home that we could all afford. We had to all agree on.
Yep.
And the home we placed my dad in, care seemed very nice. He was not on hospice. I was hoping he could get some home health, but he didn't qualify for home health. But one day, 3 weeks in, he's at the residential care home. I get a call from the social worker from a hospice. And she said, hey, I went to see your dad today and just wanted to give you a follow-up. He was doing well. And I said, who is this? And she said, this is so-and-so hospice. And I said, you know what? I'm his daughter. I'm a nurse. I'm his medical power of attorney, and my dad is not on hospice. I've never signed anything. He has never signed anything. And she backpedaled really quickly. Yeah. She was very honest and said, honestly, this is my first weekend to work with this company. Yeah. So long story short, I was so upset because I do love our Medicare, services that we have out there. I want it to last for when I need Medicare, So I wound up calling the state. I called the Office of the Inspector General, filed a report. Oh, yeah, because that was fraud. Yeah. And what they did was they patted her on the hand, spanked her little hand, the owner of the company. Oh, she made a mistake. She thought he needed care. And no, she didn't get anything signed, but it was a handshake. So you're saying
he wasn't even clinically appropriate to be on hospice?
He was not clinically appropriate.
Because as I say, we have those scenarios where, we get patients' information. They're living in assisted living or independent living. And sometimes the information about a medical power of attorney comes over like on their demographic sheet. So we know automatically this is the daughter to call, this is the son to call, to get verbal authorization or whatever. And then eventually they have to sign. But sometimes we don't recognize it until we get out there. And you're like, ooh, this one can't be signing for himself. And so then we go to work on, okay, who's the medical power of attorney? And we get in touch with to make sure. But so sometimes there are times where, so I don't know if your dad was of sound mind, but there are times when they can absolutely sign for themselves.
Yes, but he never signed. He was never presented paperwork, and he did have a little dementia. It was undiagnosed. Yeah. But fast forward, so nothing happened to the hospice. My dad wound up discharging and later went on a reputable hospice that I was very happy with. But about a year later, I'm looking at the Dallas Morning News, and this woman's picture is on the front page of the Metro section. And she was shut down because she was signing DNRs. For her hospice patients. She had falsified do not resuscitates. So she did lose her license. She probably lost her nursing license.
What is the business use case for falsifying a DNR?
Well, the reason is if they're terminal you have to have the DNR. If the patient dies, if they don't have a DNR in place, then we've got to call 911, especially in communities or residential care homes. They've got to have some kind of documentation. And that's what she would do. And maybe she didn't meet with a family, or she was not having them sign up paperwork. So where's she going to get the DNR signed? She's got to come up with it herself.
Oh my gosh.
So anyway, that was a situation where she was shut down.
Yeah.
Thank goodness. But
fortunately, the nurse had called you to at least let you know, hey, we're admitting your dad on.
But what if I didn't know?
Yeah.
What if I wasn't educated in home health and hospice and said, oh, okay, well, I didn't realize my dad's supposed to be on hospice, but okay, well, I guess that's what we need, I don't know. It's just sad.
Yeah.
But
there's a doctor writing orders, though. There's a doctor and a nurse that went out there and said he's appropriate.
But maybe the doctor is just one of those medical directors that, is paid a few $1,000 a month to sign paperwork.
Yeah.
I don't know. But anyway, we just have to be more accountable. Our teams have to be more accountable, the doctors. And I think there should be very strict rules. I think there should be major consequences. And, kind of like you said, I think people that exploit the elderly and scam Medicaid, Medicare, they should be thrown in jail and throw away the key.
Right.
I mean, that's because they're going to be an elder person one day.
A little bit of there is fraud happening for sure. We see it. We've experienced it. We've probably worked for companies where we've seen I'm not working here anymore. So that does happen. Some, though, of what gets reported as fraud isn't necessarily. It's what's in the eye of the beholder. So you'll have like a review person, a nurse within Medicare who says, I don't think that this service, home health, whatever, was clinically appropriate. But you'll have a nurse, a PT, and a doctor who all saw that patient within the last week going, yeah, of course this is appropriate. They will call that fraud. That's not fraud. That's somebody else's interpretation.
And a lot of it is documentation.
Yeah,
if somebody's documenting incorrectly, which I think is crazy too.
Yes. So they're still providing skilled intervention, but because they didn't document to the T, it's being called fraud. So not everything we see as fraud is actually fraud. That stuff that you're talking about is fraud. But if it's a documentation error or, it's too skimpy on details or whatever to really show the need for skilled therapy or skilled nursing or whatever, that's not really fraud. That's just a documentation error.
So moving on, there was another story that came out that there are a lot of companies going bankrupt, filing bankruptcy, a lot of senior living communities. And I find that interesting that our senior population is exploding, but these buildings cannot stay afloat. So what are your thoughts? Why do you think that's going on?
It's not systemic. I don't believe so, because you and I have friends who own some of them, and they do quite well. Like they're very financially healthy. And so that is not, it's operator, some of it's operator error. Some of it honestly is a consequence of what happened with I think it was the fastest sequential rise in interest rates in like the history of mankind that happened over like the last few years. We had, went from like 0% interest to, I think they topped at somewhere around 5 or whatever. But a lot of these loans are like bridge loans. They're short-term temporary loans that you eventually have to refinance. And when you got your initial loan at 2 or 3%, and now you're refinancing at 7%, you're now underwater because you didn't write up the deal for this assisted living or whatever, factoring in a 7% interest rate on your mortgage, right? So some of that is what happened. So like BlackRock, I want to make sure I quote this correctly. BlackRock was one who'd invested $1.8 billion into senior living right around COVID. And they are now selling that at a $600 million loss.
Whoa.
Yes. So even like the big, huge conglomerates that invest a lot into commercial real estate, even senior living, they got stung by this too. I think part of it in BlackRock's own admission, they won't admit this like very upfront, but you can read between the lines what they're saying. And their own admission was they were not the operators of said assisted living.
Right.
They hired operators like contract to go out there and manage these properties, and they were just the owner. Like they owned the real estate. And so one industry insider, I love the way he put this. He said, with regard to buying like an assisted living, he says you're buying an apartment inside of a hotel, inside of a restaurant, inside of a medical clinic. And if you don't go into it knowing that, so BlackRock that buys up commercial real estate and single family homes and blah, 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 they're now, because they see the same thing that everybody else is seeing, like, wow, we're going to talk about this in a second, the largest influx of seniors, like in terms of like population size. And so, if you study trends and you watch how the baby boomers have moved through, they move markets, right? The diapers went crazy, and kid toys went crazy as the baby boomers were having their kids. And now we're kind of seeing that as they're in their twilight years too. So things in senior care, senior health care, whatever, assisted livings, those are going to have a robust market for them to, grow companies on. But BlackRock didn't understand exactly the nuances that happen within assisted living. So they're selling for, a third off of what they bought them for.
And they're asking, the thing is the rents are so high now. It's crazy how high they're getting.
Some of that's market though, right?
Yeah.
So if I've got, I don't know, In-N-Out Burger paying, I don't know what their rates are, $15 to $20 an hour for someone to work at a fast food restaurant, I'm going to have to beat that rate, it seems like, to get someone who's willing to do showers, diaper changes, transfers. It's a lot of heavier labor and sometimes messier labor. So as inflation unfortunately drove prices up, it drove up labor rates too. And so some of that, like if you talk to the operators that we know, their biggest expense is not the building, it's the labor. And so unfortunately, as all the labor rates have increased, it also increases the rates for assisted living. And I am aware, and you are too, that there are some places that are trying to carve out, so it's the rest of us, right? The high end folks, they're not really price sensitive, right? They
want the very best.
Whatever number you want,
right?
They can meet, right? And then you have the lower end folks who are, they're on Medicaid. Unfortunately, there's not a lot of those, but they're taken care of because the state will actually cover their rents in those places. Who gets squeezed is who always gets squeezed. Mm-hmm. It's the middle of us, right?
Middle class.
Where it's too expensive for a lot of them. And so there are some places, some companies who are trying to carve out this middle ground of, we know that we need to be in this kind of moderately priced range. But I was telling you, like the number one expense for these assisted livings is actually the caregiving side of it. So if that's the case, where do you see the expenses cut to get to this rent payment? You see limited caregivers, right? And so again, they're carving in a market. It's a necessary part of the market, but they don't have the caregiver support that you think mom and dad should get. I'm going to tell you, the reason why the rent is so low there is because you're not getting the caregiver support. Now, I'll tell you, that's by and large. There are probably some examples where that's not the case, like some residential care homes. But if you're going to a larger community that's kind of mid-tier or whatever, you're probably going to see a little bit of a less caregiver support there, just because that's their number one expense.
Mm-hmm.
Yeah.
I always say we're as good as our worst employee.
Yeah.
If then I dealt with that at Acapella. I had a caregiver agency. I had, some that just weren't as good as others, and you'd love to work the good ones everywhere.
All the time.
And clone them.
Yeah.
Well, that's really interesting.
Yep. And then the other thing we talked about going into the senior living part of it was this growing size of the aging market. I think you sent me an article on this, and it was talking about that it had to do with a couple things. Before COVID, the hospital utilization, so we'll call it the occupancy rate within a hospital, was 64%. So in a hospital, ABC hospital average, you had 64% of the hospital beds were occupied, on a daily basis. I think it was during COVID or post COVID, it's now 75%. They're projecting in the next 10 years, it's going to be 85%. So we're seeing this supply constraint, and some of it's beds, some of it's staffing.
It's staffing.
At the same time that we're seeing the largest influx of over 65-year-olds. And so one shocking stat was we're going to have a larger cohort of over 65 than we will for those under 18. Like that's a massive shift, right? And so the questions now are, okay, if we have this happening, and so there was you sent me a video from UCLA, and they were talking about there's two sides to every story. There's probably like 12. Their side of the story was all these mean, bad private equity firms are going and buying these hospitals, and then they're shutting them down. They're not going into business to go shut hospitals down, right? So, but did they mismanage them? Maybe. But their point is we've lost some hospital beds. And so we're seeing some compression in the amount of hospital beds available nationwide. And so they're starting to think of different alternative ways. And so we had, for example, since COVID, we had a hospital at home kind of waiver, if you will. It was a demonstration project. And because Congress does what Congress does always, which is wait until the last minute, which, by the way, if you're going to do a demonstration project that is showing positive gains, maybe, just maybe, we get off our asses and we actually sign legislation before it actually expires. They decided not to do that. So last minute, actually into overtime, they're now starting to authorize the hospital at home
See, I love
demonstration
that hospital at home project. I think that is brilliant.
But if you're think about it from you're a business owner, think about it from a business owner's perspective. If I don't know what that program is going to look like in 6 months, I'm not expanding it. Right. And so a lot of them were worried about having to shut down. And I can't remember all the details, but I think there had to be re-upped, if you will, or re-signed in law by like December. And then they were late. I think the House signed it. And then I think the Senate signed it maybe in January. I may have my dates picked up, but I do know because I read that there was a lot of angst about the hospital home program potentially going away. So all that to say, like there are some strategies to help alleviate some of the beds. And so some of those are like the hospital home program. UCLA was talking about they kind of have a triage process where if you're not dying, then they'll do it's a urgent clinic essentially on site tomorrow morning. So like the next morning, you'll come back and you'll see an urgent care doctor at the hospital. So it's kind of like urgent care. So they're trying to alleviate some of the pressure on the beds there. So they found that's helpful. I have some colleagues of mine who are physicians that are deep into the telehealth space. And so they're very they're very bullish rather on that telehealth can have a meaningful impact, I think for sure on urgent care kind of stuff like that. You still have to be smart on the triaging. So there's always going to be those buts. But there's a number of different things that they're looking at. Some of the other things that Medicare is actually working with, they're doing hospital readmission penalties, right? If a patient comes out of the hospital and then goes right back, we've just filled that bed again, right? So if we can reduce the hospital readmissions, those kind of things help. So transitional care programs at home, all these things. There's a number of different levers that we can pull on. Obviously from my perspective, from the home health side, we focus a lot on functional uncertainty. There's a lot of really good research on, if you can identify when somebody's starting to drift poorly functionally with their mobility, and sometimes it's subtle. You won't pick it up without actually testing it. You can have a dramatic reduction in falls and hospitalizations, and so that's what we focus on. And so there's a number of different dials and levers that we can play with to reduce the stress or strain that the system may or may not be having in the next 10 years as we have this giant influx of 65-year-olds retired.
Well, I'm in my 60s and I early 60s
I had no
still,
idea.
Thank goodness. And well, yeah, right. But back in December, so I got sick, like this virus that everybody's getting that lasts 2 and 3 weeks. Well, I got sick of staying in bed, so I thought I'm just going to get my sewing machine out and sit and sew. Was against doctor's orders, but I got up, got my machine. Anyway, I wound up tripping, falling,
That's right.
and I hit the middle of my back. It was so painful. I mean, I couldn't even sit down. So I did go to the ER. Mm-hmm. And I had the best experience.
Good for you.
It was one of the bigger, better hospitals here in Dallas. But what they did, they called me back, did my vital signs, and they said, okay, we're going to get you an x-ray. A nurse practitioner came out to the lobby. Said, I'm going to get an x-ray of your chest. Went in, got my x-ray. They had me wait back in the lobby. Then I got called in by a doctor. Went into this little room and they said, look, you've got some fractures. Really you just have to take it easy. There's not a lot we can do, blah, blah, blah. Went home and just rested until they healed and felt better. But I had a great experience. And so I thought, wow.
The shocking thing is when we come out and we say we had a great experience.
I had a great experience. It was horrible.
Right.
It was so painful. Yeah. But what I was going to say, I didn't have to wait hours and hours and hours. They had figured out a way. The sicker people were going into rooms, and the ones that weren't so sick.
We have some good. We're very blessed here in the Dallas area. We've got some good hospitals here for sure. Yeah,
I know. But I just want people to know that when you smell a rat, it's a rat. If you have issues, complain, call the office of the inspector general, call a, aging life care specialist, a nurse navigator, call a reputable company like yours, Brian. If you have questions, like, who do you recommend for rehab? We're going out, we know we're going to use Nexus when we get home, but they want us to go to rehab, and I want your opinion.
Yep.
So
we get asked that regularly.
Absolutely. Yeah. I do too. I get calls all the time, and don't be afraid to call and ask, because we're here. We want to be a resource for people.
That's right.
I want everybody to have a great experience.
That's right. Yeah. It's aging poorly can be really challenging, not just for the senior, but also for the family members. And that's a lot of the reason why we do the show, is just to help educate people and connect them with the resources that we've already vetted, that we trust, because it's the wild, wild west out there. There's a lot of different options, and you just don't know if this is like your first time with an aging parent moving into this arena. Like, how do I know what I'm supposed to be doing? And so having a nurse navigator or concierge, or having a home health company that's got a large Rolodex and a lot of relationships and can kind of guide you through, hey, this is where we recommend. By the way, when you're in the hospital and the rehab, here's a few things to look out for while you're there. Those kind of things can be valuable.
And I think I want to say too, when your parent or loved one is complaining about something, listen. They're not going to be happy. They don't like the food. You always hear, I don't like the food, or, my therapy, was just a minute. They won't let me walk out in the hall.
Yeah.
I had a gentleman that literally was in rehab for 9 days, did not have one therapy session.
Crazy.
For 9 days.
In a rehab hospital?
In a rehab hospital.
Ooh.
We wound up moving him, but it was terrible. But if they mention things and you're not getting the answer you want, go up the chain. Don't be afraid to ask, because these are our Medicare dollars.
Yep.
You have insurance. You have Medicare, Medicaid.
I think some of the fear is they don't want any kind of blowback or retribution by being the negative Nancy, right?
I know.
But there's a difference in criticizing, going, hey, mom's food is 5 degrees too cooler than I would like it to be, versus I'm not actually getting therapy in a rehab hospital. Like, there's a big difference. And if there's things that are raising that level, you absolutely need to be making stink about that, because you've been part of these before. You've seen me talk on this. Like, I talk on frailty and hospital acquired frailty all the time, and a senior in a bed for even 24 or 48 hours, you start to see a really fast cascade of what the literature calls a cascade of dependency.
That's
hate the
what
term.
I wanted to sew.
Yeah. Because you wanted to keep moving?
I wanted to keep moving.
Next time, just do needles and crochet.
Yeah. I know.
Make a blanket. Yeah. So anyway, but yeah.
Yeah. Lots of great information, Brian. We have a great guest next time.
We do.
And we're excited for our next episode. But thank you so much. Remember, call us if you need us, have questions, don't understand something. We are always here for you.
Yep. Great. Thanks, Joe.
Have a good day.
Bye.